Hi, I'm Jen. I'm an FY1. Hi, I'm Jen. I'm an FY1. My advice would be for the first few months, if you've got a list of stuff to do, all good.
Hi, I'm Sarah. I'm moving to FY1 start year, right?
Hi, I'm Jen. I'm an FY1. My advice would be for the first few months, if you've got a list of stuff to do and it seems like loads and you're getting beaten left, right, and centre, you can literally only do one thing at a time and try not to stress. You've got a family, there's lots going on. You can just only work as fast as one person can. So just try and prioritise and just do one thing at a time and just take it easy and don't worry if you're messing up. All good.
Hi, I'm Sarah. I'm moving to FY1 start year, right? So my big advice is just to have fun when you're working. Obviously the job can get stressful, can get busy, but you are allowed to have fun with your colleagues or FY1 pals. Go to the mess, hang out there, and yeah, just have fun and enjoy it.
Morning, how are we doing?
Good, you just checking. Michael, do you mind sending me the whole thing that is mine, please, so I've got a record of it. Thank you.
No, I've muted the record.
So if when you said we could move when I'm doing mine, I mean, I don't actually necessarily want to move. I suppose what I need to do is be able to
time, and then it'll start.
So Michael's going to give us a clicker so that we can advance the slides. We're going to see this. It's the
Caroline, is it okay if I just leave my notes up here? Is that alright? Lovely. Great. Is it top down Joe's going to do this year?
I don't know. Or Jungle Book and Balloon like you had then. Jungle Book, I'm not a bit old. Talking about this year.
It's just the same story, isn't it? It's just the same story. So we should have, TLC should have something on it. Clyde should have, we're expecting the Jays turn up at Paisley and then Clyde. How many were you expecting it? So we'll have trainees, Caroline, in various sites at the hospitals. Some will be at home, some will be on site. What's that? What was it?
Welcome everybody to West of Scotland FY1 Induction. We've been running this in the West of Scotland for the whole new cohort of FY1 trainees for about 5 years now, and it's our opportunity to welcome all of you as a group, all of you who are joining us. My name's Caroline Whitton. I'm the Associate Postgraduate Dean for the West of Scotland, so I lead foundation training in the West of Scotland. This is what today's going to look like, and I'm sure you will all have had this sent out to you. So, welcome. Today is the first day of the rest of your lives, of your professional lives, and from this moment onwards, you no longer have to apologise for being who you are. You never ever have to say again those immortal words, I'm just the medical student. You never have to be just anything again. From this day forwards, you can introduce yourself as, I am your doctor. So I'm asking you all to embrace that and enjoy it. Enjoy the moment. So, in the West of Scotland, we have 489 FY1 trainees. So I'm hoping I'm speaking to 489 people right now. We have 34 programmes in the West of Scotland. Each have 15 rotations in FY1, 15 in FY2. A couple of them have a smaller number, 12 in each. Most of our programmes are split between GGC and the peripheral boards. Some are located in one board only. And we have one academic programme which is linked to university posts. So, across the West, across FY1 and FY2, we've got about 950 trainees. And you can see from this map that we actually have more than half of all trainees in Scotland. and this shows all the various health boards in the west of Scotland. So, what is foundation training? What is the point of this? So, to take you back 30 plus years, I started life as a house officer. And when you were a house officer, you started on the 1st of August, regardless of whatever day it was. There wasn't actually an induction apart from the ward sister saying hello and showing you where to put your coat. That was probably about it. And you just had to kind of drop in there and get on with it. But we've changed that, and we want to introduce you properly, and we want to welcome you in, and we want you to feel comfortable. So foundation training is an essential part of your training because it takes you as novices and it trains you spirally so that you become more independent. So you have increasingly supervised independence. So the independence is increasing and the supervision reduces. And we want to get you to the point where you're ready to enter specialty training. And what foundation training does for you is it gives you extensive and thorough training, and it focuses on the generic capabilities that you're going to need and are going to take you through your professional lives as doctors. And our purpose is to take you from being a medical student to being an independent practitioner. So when you enter FY1, you should all have your provisional registration, okay? That's crucial. If there's anybody amongst the 489 of you who doesn't have provisional registration, you need to let someone know about it sharply, okay? As you exit FY1, you gain your full registration, and then as you exit FY2, you get your certificate of competence, and you can go into any specialty training job. So the purpose of foundation is to aid you in your ongoing learning and, crucially, to guard patient safety by ensuring that you are competent, you are capable, and you are, very importantly, caring doctors. In the 70s, the 4 stages of competence were put forward as an idea. So they began with unconscious incompetence, which is really saying that you don't even know what you don't know, or what you know. And that's you, that's all of us as we were pre-medical school. As you graduate, you become consciously incompetent, which means you at least know what you don't know. By the time you're through foundation and through specialty training, you're heading towards conscious competence, which means you know what you're doing. Sometimes you're thinking about it though. And then hopefully by the time you reach the pinnacle of your careers and you're consultants and GPs and associate specialists, you're not thinking about the mechanics of the job, you're thinking about doing the job, diagnosing, treating, managing, making people better, helping people, without having to think, oh, how do I do that? And that's the stage of unconscious competence. Because your education really starts after your degree. So your degree is a starting point, it gives you the basis, but the majority of your education happens afterwards and goes on for the rest of your professional life. So, it's a big job, you're stepping into big shoes. Who is there to support you? Well, we've got the NEST team, so the UK Foundation Programme team and Scotland Deanery. And within Scotland Deanery, we've got the lead dean, we've got the school director and school manager, we've got the associate postgraduate dean, that's me and my 4 consortium leads. We've got programme directors, you'll each have your own foundation programme director, the NEST admin team, and your educational and clinical supervisor. All these people are here to help. This is the Scotland team. You may or may not meet any of them. You'll probably see their names from time to time over the next 2 years. So our lead dean is Professor Clyde Mackenzie. Our school director is Fiona Cameron. She's the associate postgraduate dean in the East. Duncan Henderson is the programme board chair and associate postgraduate dean in the South East. Joy Miller is associate postgraduate dean in the North. I'm associate postgraduate dean in the West. And Christine Rhea is the school manager. Who else is there to support you? the health board team. So your health board is there to support you through your Director of Medical Education, and you're going to meet our GGC Director of Medical Education soon. Your local education provider postgraduate admin teams are there to support you, and your educational and clinical supervisors are based in the health boards. So what's my role? My role, first, foremost, underpinning everything, is to ensure patient safety. That's really my fundamental purpose. But the way I do that is to ensure your safety and your ability to do your job. So I'm responsible for your education, your training, and the sign-off at the end of your programs. And I want you to have a fantastic training experience. I really do. That's really important, because I can tell you, if I close my eyes, it's 32 years ago, and I was starting in the infectious diseases unit at the City Hospital in Edinburgh. The time has gone like that. So don't waste a moment of it, because it will be gone before you know it. So I will oversee your education programme and your placements. And with my team, I'll supervise your progress through foundation. And I'll meet any of you who are struggling and need assistance. And I'll help any of you who face challenges along the journey, because I'm here to support you all. And I say this every year, and I say it from the bottom of my heart. If you are struggling in any way and you can't get help, I want you to come to me, and I will find a way to fix it. Our consortium leads, in the West we have 4 consortium leads, and that's because we've got 34 programmes. So each consortium lead looks after between 8 or 9 programmes, and they oversee your programme and your placement, and they supervise your progress through foundation, and they will meet with those of you who are struggling and need extra help, and they'll help those of you who face challenges along the journey. So you might find yourself meeting myself and one of the consortium leads, because we work very much as a team. Your programme director, this is your direct link into the programme, your foundation programme director. And each foundation programme director manages one programme. And they are there to support and help you and to oversee the assessment. They'll sign you off at the end of F1 and F2. They approve your study leave, and they are there to assist you whenever you need help. Your educational supervisor supervises and manages your progress through each placement. They'll make an educational agreement with you. They'll help you to set and achieve your goals that get written down in your personal development plan. That keeps your mind focused on what you want to get out of posts. And you should meet with them at least at the beginning and the end of each block. They are responsible for signing off each block. And I'm going to insert this now, and it will come up later, but in the final block, you need to have met them before midnight on the 31st of May in order to be successful at RP. But I'll remind you about that through the year. Your clinical supervisor oversees your clinical work. So it's very important that at some point during each block you actually work with your clinical supervisor. I'm keen to know if that's not happening, and I'd like you to let me know, let your foundation programme directors know if you are not at some point working directly with your clinical supervisors. Your clinical supervisor is there to provide feedback during your placements, to help you set and achieve your goals. Again, you should meet with them at least, formally at least, at the beginning and the end of the block, but the anticipation is you will be working with them, so you'll be seeing them more often. Sometimes, often, one person does both roles. And then the NEST postgrad admin team works closely with me to administer the programs, and they are a wealth of information, and they will help you. And the health board postgrad admin teams they manage foundation at each hospital. They provide a link to the foundation program director, and they might administer the education programs in each hospital. Again, they're there and they will be able to answer questions and queries for you. Our job is to keep you safe. So if you have any problems, come to us. And the earlier you come to us, the quicker we can fix the problems. So this shows how it's organised. And this is you. And we're here to help you. Okay, I want to introduce a couple of concepts. One is the buddies concept. We introduced this last year, and we buddied up every FY1 with an FY2. And we did it within programmes, but the feedback we got was that it would work better if it was within hospitals. Now, mathematically, the numbers don't exactly match, but to the best of our ability, this year we will buddy you up with an FY2 within your hospital rather than with an FY2 within your programme. And what will happen is that your foundation programme director or somebody from the postgrad admin team will contact you with an email that links you and your buddy. And then you can anticipate that your FY2 buddy will contact you. And then they're there. What you get out of it is entirely up to you. If you want to contact your buddy, contact them. If you don't. Entirely up to you. They're there to help you and provide a bit of extra support on a kind of informal peer basis. And at the end of the year, we'll evaluate whether it's something that's worth doing. And also we have several groups that are important within Foundation in terms of what we do and what we provide, because we innovate and we iterate, and there's only any point in us doing it if you're getting value. So we'll be looking for representation on these various boards. Probably the most important one to take note of is the Foundation Trainee Forum in the West. We have a very active trainee forum. One of our Foundation Programme Directors sits in and nominally leads it, but in fact it's the trainees who lead it, and they will be doing a presentation about it later on. So get involved, because it's a way to make your voice heard. So, how do you make the most of FY1? Well, you grasp every opportunity to be part of the team and to provide patient care. You've got to get in there, roll your sleeves up and do it. You learn from your clinical cases. You be as involved as you possibly can be. Help everyone. We're all in this together. So these ideas came out at the beginning of the pandemic, but to be honest, the NHS is still not in a great place, and we could all do to support each other. And the more support we can give each other, the better all of our experience will be. So help everybody. Be courageous and support each other. And very importantly, ask for help and support whenever you need it, because when you need it, help and support will be there. These are the NHS Scotland values: so care and compassion, dignity and respect, openness, honesty, responsibility, quality and teamwork. And these are front and centre of what we do in foundation training. So above all, be kind to your patients. They need you to be kind to them. Be kind to your colleagues and be kind to yourselves, and have a fantastic time. And these are some websites you might find useful over the year. Okay, thank you. I'm going to introduce Fiona Winter, who's the Director of Education and Assessment at the Royal College, and would like to say a couple of words. Thank you, Fiona.
Thanks, Caroline. I'm just going to wait for my slides to pop up. That's it. We're good. Thank you. So, first of all, huge good morning to everyone and welcome along. We're beaming out to you this morning from the Royal College facilities here in St Vincent Street in Glasgow. And we're delighted to be hosting your speakers here in the college this morning. I think on your programme I might have been overbilled as the President. The President was hoping to be with you this morning and unfortunately is not able to be. So I'm here on behalf of the college just to welcome you along. My role here is Director of Education and Assessment. So I look after all of our education offering and all of our exams. And I think in that role I'm likely to come across a good number of you in your early years as a trainee. Now I suspect you've been waiting to get started on today for quite some time, with a lot of anticipation, possibly a little bit of trepidation as well. And Caroline's told you about some of the support available to you. I just wanted to take a couple of moments of your time to let you know that the other support that you can access is through the college, and we hope to work with you in the coming months. So just wanted to let you know some of the things that we offer here at the college for you. You're going to, when you return to when you're in the hospital, you're all going to pick up your little welcome pack from the college. I'll wave one here. It includes a little prospectus that tells you about the courses and conferences and the support that we offer as a college. You've also got a pen, very handy, but most important, very snazzy. We all love them. Your lanyard with your snazzy badge. So we hope that's useful to you, and we hope the prospectus will give you some information to work through. You'll see from that prospectus that we offer a number of courses for you, and we're going to come on to talk about joining the college. For just £3 a month you can join the college, and that will give you discounted access to both online learning and also face-to-face learning. Those discounts can be up to £180 for some of our courses, so it doesn't take into account to work out that can be a great saving for you for just £3 a month. It will also offer you the chance to have access to some of our scholarships and our awards as you work through your career, and access to our library, including support to access materials that you need. So when you do have a chance to take it all in, and I know there's going to be so much to pick up in the first few days, take a little bit of time, have a flick through that prospectus, and of course, if there's other things that you would like support about, we'll give you some contact details as we move through. In that pack, we'll also give you access to a survival guide for foundation trainees. And whilst it's great to get experience and knowledge from those of us who've been around for quite some time, there's nothing better than hearing from the people who were in your shoes just last year, 2 or 3 or 4 years ago. And our trainee committee here at the college have put together their survival tips. They are another support for you, and if you feel you want to access support perhaps from outside your hospital, we'd encourage you to get involved in our trainee committee. It's an interactive online document with all these survival tips, and you'll see we've also given you the Twitter handle for our trainee committee. So if you haven't already had a little look at what we've got online, you can access both our college Twitter page but also our trainee Twitter page. So a little bit of an advert for us. If you would like to get a little bit more involved in the college, of course you can look online and find out more, but we'd love for you to join us as well. The cost of joining the college as an affiliate member is just the same as a cup of coffee once a month. It's £3 a month. And you can contact us via our engagement team or at the little link that we've put on the screen. Now, I don't know if you'll be able to see on the camera, I'm sure my colleagues can help me with this, but I just wanted to introduce one of my colleagues to you. This is Sarah O'Connell. She is the manager who heads up our engagement team. Sarah's team have been responsible for making sure that you do get your snazzy little lanyards, and you're likely to come across Sarah and her team at the hospital where you work and through some of our events. Her team are there to make sure that if there's things that we can do to support you, we can put that together. So hopefully you'll meet both Sarah and myself in the coming months. Thanks, Sarah. So that's all I wanted to say to you today. I know there's so much to take in these first few hours. So really just a massive welcome from the college. I'll leave you with a couple of tips, and I'm not a clinician, so these are not clinically focused, but a couple of tips from my first days at new jobs and my first weeks in new roles. My first tip is a do. Do ask about abbreviations, acronyms, terminology and lingo that you've never heard before. Those of your colleagues who've been around for a few years forget that they didn't know these things on day one. And quite frankly, sometimes they've made the words up anyway. So ask them, write them down and get familiar with them. Don't be frightened of that. And my second top tip I have learnt from very harsh experience over the years. Never, ever wear new shoes to a job until you've broken them in. So with that, I'll leave you today. Thank you very much for your time. I look forward to meeting with some of you over the coming months, and I wish you all the best as you begin your new careers. Thank you. I'm going to hand over to Lindsay Donaldson now.
Thank you very much, Fiona. And a huge welcome from the Directors of Medical Education. So I am Lindsay Donaldson. I am Director of Medical Education in NHS Greater Glasgow and Clyde, and I am also an intensive care consultant at Glasgow Royal Infirmary. And on behalf of every single DME in the west of Scotland, I'd like to say a huge hello and welcome to the first day of your working life as a doctor. Myself and Dr. Jennifer Armstrong, who's our Medical Director, are welcoming you to your health boards. And I'm just waiting for the slides to come on for the health board welcome. Lovely, thank you. So, what on earth is a Director of Medical Education? Well, as the name slightly suggests, we oversee medical education within the board. And within Glasgow, that's about 1,500 trainees, there's about 800 medical students, and those numbers will go up. And we're also got a role in clinical fellows. And Caroline said something earlier, we're all in this together. We're all in it. Caroline works for NES, I work for Greater Glasgow and Clyde, but we're all in it together to make it the best experience for you as an FY1, and also to support you and in your journey to become the best doctor that you can be, to support you in the specialty that you want to become and your journey, and also we want you to stay with us in Scotland. And we have many relationships as DMEs. We have relationships with service, we have relationships with the GMC, the university, the deanery, and so it goes on. So relationships are incredibly important to us. And our key work streams within medical education are induction. This is hugely important to start off on the right foot, to give you the tools that you need as you start. And also, we're involved in the quality control of medical education. As I said earlier, we want it to be the best experience it can be. Educational governance, ensuring that you know who to contact, and also if you need to raise concerns, and also either clinically or educationally, and we're also involved in supporting your trainers. I guess it goes without saying that if you don't have any trainers, there won't be training. And our trainers are hugely important to your progression, but also the roles within our hospitals and health boards. And we know that from the GMC that we need to care for our doctors so that you can care for our patients. And I want to put a trainee, just a random trainee, for example, say Fernando. We've got somebody, trainee right in the middle here, trainee-centred care. And who looks after you as a trainee? Who looks after this person? So educationally, Caroline's gone through the educational governance around your clinical supervisors, college tutors, but also from a clinical governance point of view, you have all these people looking out for you and supporting you and working with you. You're part of this massive NHS pyramid. We're all integral to that success. So you've got peers, your pharmacists, your nursing staff, your SAS grades, consultants, senior trainees, your chief residents, and also your rota coordinator, your allied health professionals. All of these people are working to deliver care to our patients and to support you. But it doesn't stop there. Keeping you in the centre, we've also got our clinical directors overseeing the work, our clinical service managers, our clinical leads, our general managers, and of course Caroline's gone through the educational point of this as well. So there are not two sides. If we could animate this would be circling you at all times. We have our associate medical directors, we have our chiefs of medicines, our directors. All of these people, again, are there from a clinical governance point of view, looking after you and the service. This is all overseen by our chief executives, our chief operations officers, our medical director, and we'll hear from Dr. Armstrong in a second, and also our chairman. We've got NHS Education for Scotland, there's colleges, our postgraduate deans, and of course overseeing all of this is the GMC. So I want you to just imagine yourself right in the middle with all of these people looking after you and looking out for you. And each little circle there's a person with a name that is interested in your career development and how you're working and how you're getting on. And again, it's back to that, just being the best doctor that you can be. I don't think we can do any induction without COVID. I know that as a year group, you have had a tough time with COVID. There has been much disruption. I think everybody on this call will have had an experience during COVID. And your experience will be no greater or no less than anybody else. There are no top trumps in COVID. We've all had an experience, and it's still with us. And you will be aware of that. In fact, some of you might have COVID right now. It's still with us and will still be with us in that cyclical change. And things may change, and we will be flexible enough to accommodate these changes. And if I go back to caring for doctors, caring for patients in the GMC, one of the things that I'm very keen to introduce you to is really becoming part of the team. And the ward shadowing, well, you're joining that team, and where does that happen? It clearly happens in your ward. And when? Well, you'll have at least 2 full days of shadowing. Some of you will have more, depending on where you have come from. Your ILS, some of this will be health board specific and will be directed by your local teams. And this helps you become a team player and a team leader within your ILS teams. When we think about induction and shadowing, you will learn what the working day is like. Some of you, if you're University of Glasgow, will have been through our systems and you'll have done your P4P in your various boards. Some of you will be coming from outside of Glasgow in the west of Scotland. Your working day, the priorities and tasks, and also knowing your roles and responsibilities, and knowing where things are, but also where things go, and that includes you. And a huge part of the shadowing experience is thinking about your well-being. And what does that mean? Well, there are logistics about well-being. Where do you put your coat? Is there a locker? Where are the toilets? Where are the showers? If you cycle in, where do you put your bike? And also there are logistics about hydrating and eating. Appropriate rest and breaks and where you go for those. And there was some little clips playing, I don't know if you've seen those, but just the fact that there are doctors' messes, there are areas that you can sit down, relax and catch up with your pals. Pace yourself. It's busy. You know that the health service is busy. But there are some things that can wait and there are some things that can't. And as time progresses, you will get really smart about those. You will know what can wait. Have your drink, have your lunch, have your rest, and manage your time. Sometimes it may feel it's out with your control, but actually if you're ever feeling hungry or angry or you're thirsty, just take that break. There are laws and rules and regulations about breaks, and they're there so that you are at your best when you're looking after yourself and your patients. And if you can, try and get into some really good habits. Hydrating is one of these things. You do feel better, and I know that you do that. And also getting ready. There will be some things that you have to do in these 5 days. This is the start of your working career. You're now employed. You're technically employees of NHS GGC, but you're working in various boards. And so you actually are an employee now, and there are some things that you have to do as an employee, and that is our organisational induction, depending on which health board, your IT training, it may be different on each board, and also your statutory and mandatory training. And these are legal requirements as an employee. Some of you will already have done that during P4P, some of you will be doing that just now. So that's you getting ready to start next Wednesday. And as the days progress, the tensions will possibly start, but you've got all of these days just to settle in and also get prepared, get ready, meet your peers and meet your colleagues that you're going to be working with. So there are no stupid questions. If you don't know something, ask somebody. And I really liked Fiona's comments about acronyms and abbreviations. There are so many in medicine. And if you don't know, it's not a daft thing to say. Just explain that to me. If you're worried about something, if you're worried about patient care, if you're worried about yourself, or you're worried about a colleague, again, please tell someone. There is always someone, just like that diagram shows, you're right in the middle of it. And there are so many people looking out for you. Your first port of call is often your educational supervisor, but also you'll be working with consultants and senior trainees. They will all be approachable. Let them know. Please listen if your colleagues are worried about something. You will be working with enormously experienced colleagues that have been in the health service for a long time. If they're thinking or possibly saying things like, "Are you sure you want to do that?" Just have that little warning sign. What is it they're seeing that maybe you haven't seen? And ask them gently what are perhaps they thinking. And that's working as a team to get the best outcomes. And there is always someone to ask and talk to. And with that, I'd like to introduce Dr. Jennifer Armstrong, who is our Medical Director within NHS Greater Glasgow and Clyde, to welcome you on behalf of the Medical Directors in the West of Scotland. Thank you very much indeed.
Good morning, everybody. My name is Jennifer Armstrong, the Medical Director of GGC. I'd like to start with our story of a patient who was admitted recently to the Queen Elizabeth Hospital, and I'd been given permission by the family and the patient to tell you this story. So just a wee bit about the patient. It happened on Friday the 3rd of June. If you remember, that was the Platinum Jubilee of the Queen. And the patient was an 89-year-old man. A wee bit about him: he was a lawyer, still is a lawyer, and he had received a certificate from the Law Society saying Scotland's longest serving lawyer, in brackets, without complaint, close brackets. So I don't know if there's 100-year-old lawyers with loads of Law Society complaints, who knows, but this is what his certificate said. And he had actually no medical history to speak of. All he had was a bit of rough skin in his elbows, and that was it. He looked after his 85-year-old wife, and she had been a GP in the Gorbals for 30 years. But unfortunately, like many elderly people, had developed vascular dementia, and he was the main carer for her as well. So on this day, on the 3rd of June, he developed severe pain on his tummy, just said tummy pain. And he called his daughter, who lived near, who'd just seen them, to come over. And as he sat there, it was severe pain, it was episodic, and it was around his whole abdomen and also around his epigastric area going through to his back. After a bit of toing and froing, he was admitted to the Queen Elizabeth Hospital, where he was seen by his first junior doctor. And the junior doctor looked at him, and by this point it was about 2:30 in the morning, and examined him thoroughly, took blood tests from him, and decided that he had acute pancreatitis. His pancreas amylase was about 600. And indeed phoned the daughter, who was staying with her mother, to explain all of this. So she explained it very clearly to the patient. She explained it very clearly to the daughter on the other end of the phone at 3 o'clock in the morning. And also what they then did was the FY1s around them then prescribed pain control and did their best to reassure the patient. So the patient was admitted to the level 9 surgical unit in the Queen Elizabeth, and he was seen by the consultants in the ward round the next day, or in the early hours of the next day on Saturday morning. A CT scan was organised to see what was the cause of pancreatitis. He got a CT scan on the Monday, and it was seen that he had gallstones in his gallbladder. And at this point, there had been a series of junior doctors who were clerking him in, who were giving him treatment, who were giving him reassurance all throughout that time, from CT1s to ST3s to FY1s. And the FY1s are absolutely crucial to the running of the ward. On the Tuesday, about 4 days after he was admitted, he becomes acutely confused. And he becomes quite irascible. And by this point, the FY1 in the ward had picked up, and I'm going to use an abbreviation as EGFR, which is renal function, had dropped to 23, which means it had really dropped quite dramatically, and he was acutely confused. The FY2 then phones the daughter, who was at work at the time, to say, I would like to invoke power of attorney because I believe that we need to give some treatment. I believe he's refusing a catheter, he's refusing a drip, and we need to do something here. And that relied on the FY1 picking up the results, on the FY2, and also the consultant team, who were also there as well. And you'll give a lot of, as the renal physicians would call it, salty water in your time to patients like this. And when you're looking at a patient who's nearly 90, it's a very delicate balance. And again, the FY1s were there, the FY2s were there, the daughter went up, and what she was seeing was a father, a lawyer, a husband, but she also could see what the ward staff were seeing, which was an acutely confused patient. And indeed, his wishes were overridden for power of attorney, and he was overruled, and IV fluids were started and IV antibiotics, and he recovered really very nicely. And in fact, he said it was his first time as a lawyer that he actually enjoyed being overruled. He'd been overruled many times in his career, but he was very happy that took place. Over the next 5 weeks, he had a very, very stormy course, and those of you who do surgery will realise this. He had pseudocysts, he had collections, he had necrosis of his pancreas, he developed a sepsis, and all throughout that time there was junior doctors there in the middle of the night when he dropped his blood pressure, doing CT scans, ordering the CT scans, and working very closely with the consultant team and the nurses on the ward. And he recounts, when he was asked about his recollections of junior doctors, he was very, very thankful for them. And it was sometimes the little banter moments that really made the difference for him. At one point, he was trying to mobilise. The ward had been closed for COVID, so he hadn't been able to get any visitors. He was pretty weak, but his daughter kept saying, you must get up, you must mobilise, you're going to get chest infection, blah. So he gets up, hangs on to the bathroom door, and then falls. And this was his first fall that he had. And he's sitting there thinking, gosh, if I broke my hip, I am never going to get out of this place. Queen Elizabeth was great, but you don't want to be there for 5 weeks if you can avoid it. So he's lying there, and 5 nurses picked him up, including a junior doctor. And the junior doctor, who was either an FY1, FY2, then examines him. And he's trying to kind of lighten his own mood, and he says only what lawyers can say. He said, is it you that I sue if I break my hip? And the junior doctor, quick as a flash, looked at him and said, yeah, it's me, and hope you get some money if you do, but I'm sorry to say that you won't get any money because you haven't broken anything. And actually, she did a very thorough examination that gave him real confidence. He just said her banter, gave him real confidence that he may well get home. Now, all of this was done, unless you think this is just junior doctors, under the scrutiny of consultants. And the consultants were absolutely excellent, as I'm sure if Mike McCurdy was here, he would say, a good surgeon knows when to operate, a better surgeon knows when not to operate. And the surgeon looking after him was actually, in actual fact, had been an FY1 of my husband. He was very distressed to see that. He's a consultant physician, my husband, and he recognised him and said, oh God, I was his educational supervisor many years ago. And you probably guessed by this point that the daughter in that story was me. I was the daughter there. I was there early in the morning and night time, seeing what the junior doctors were doing, and they were phenomenal. And at the end of it, as I went to pick him up, there was a junior doctor there who'd already done, because the nursing staff told me, 15 immediate discharge letters that day, and she was run off her feet, and she was able to give me the prescription and talk about his creon and his pancreatic replacement therapy. So the reason for telling you that story is that you are the backbone of the NHS. You work within a consultant team, and I have an absolute privilege to be an RO of something like 3,700 doctors of all persuasions, of all flavours, and I get the privilege to, in detail, to recommend them for revalidation. And they've all started as an FY1. They've all started where you are now, and they've all made mistakes. And I think I just wanted to say, in this room, we've all made mistakes. As Freddie Mercury says, I've made mistakes, I've made a few, I've made loads. And don't worry, you will make mistakes. Of course you will. We all make mistakes. And if I asked all the consultants in the room to put their hands up, they would all say, yep, we've absolutely done that. The key thing is to learn from them, is to look at them honestly and learn from them. And once you've done that, to let go of that baggage. Because if you carry all that baggage with you, it becomes a drag on you. And it will make you into a better doctor in the long run. So I think my advice to you is certainly learn from them. I was talking to the medical directors yesterday. We have a call once a week. We started that during COVID, and these are the medical directors across all the boards you're going to. And I said to them, what would you want me to say to the new doctor starting? And they said things like compassion were very important to patients. That little chat that you've had with them, you might not remember but they certainly will. But the other thing they said, and I thought this was really interesting, was that actually they really cared about the experience that junior doctors had, because we were all junior doctors, all in the FY1s. It's a bit like, je suis FY1. In fact, I know some of you will be great at French here, so I'm about to butcher the French language, but nous sommes toutes FY1s. That's why we really care about how you actually get on with your careers. There's a whole, medicine is great because there's a whole series of careers that you can do in medicine, and there'll be a career for all of you in it. So I wish you all the best. Think of the patients and think of yourself, and I welcome you on behalf of all of the medical directors across the west of Scotland to your jobs, and I hope you enjoy it. Thank you very much.
Thank you very much indeed. And we wish your father well. Thank you, we wish him well. So thank you very much indeed. We're going to take this opportunity to take some questions at this stage, if there are any. And I'm getting some shakes of the head to say no questions at this stage. None? No. Perfect. If I could just ask the team in the top window, would there be any way of having the slides on the desktop here, just because they're not there just now? If there would be any way of just having that, because I think that would be helpful. If we could do that, thank you very much indeed. That's super. I will then, if definitely no questions, I'm looking again to Lisa and Michael.
Just a reminder, the Twitter handle, the WhatsApp group and YouTube.
That's great. Well, so we've got social media, Twitter, we've got WhatsApp group and the YouTube. So please ask questions, and I'll hand over to Caroline to introduce our next speaker, after which you might have some questions. Thank you all very much indeed.
Thank you very much, Jennifer and Lindsay. And what we'll do now is, and also Fiona, and we're moving on to the next part of the deanery side of the presentation. I'm just gonna, sorry. So I'm going to introduce you to Dr. Brian Neely, who is our next speaker and who is going to talk you through the e-portfolio and our education and some of the things you need to be doing. I appreciate on the side it says Dr. Joseph Esperan. This isn't going to be Dr. Joseph Esperan, it's Dr. Neely, and we're just looking to see where Dr. Neely's slides are. This is one of these infamous technical glitches that's happening, unfolding in a dramatic way in front of you. So I'm going to be forced to break into song and dance very soon unless someone comes up with some slides for me. So let's all hope and pray that doesn't happen, because it's really not one of my fortes. So, guys at the top. Well, let's take a short break. Good idea. Let's take a short break. So we'll take a 5-minute pause here. So we will come back on at 9:50. Okay. So thank you.
Yep.
Welcome back everybody, thanks for your patience. We've all just been having a great chat about Tom Cruise in Top Gun Maverick, and my top tip for the day is if you haven't seen Top Gun Maverick, go and see it because it's fantastic. In the meantime, I'm going to introduce our own Tom Cruise, who is Dr. Brian Newley, and he's one of our consortium leads, and he's going to talk you through the e-portfolio and education. So we're doing it on this.
Thank you, Caroline. In terms of bragging rights, I started my first job in 1979, 1st of August I think it was. I think the induction was to be handed the bleep with an explanation of some patients in the ward. So I think things have moved on a few years. So it's my job to present e-portfolio and education, a bit technical at times, so you have to hang in there with me. This is part of a slide set that is shared across Scotland, so your colleagues elsewhere in the country will be seeing exactly the same slides. So at a very basic level, the foundation training programme is a combination of clinical posts plus a structured educational programme, and it's important to keep these two things in mind as you go through your foundation training. The requirements of the programme are set by the GMC through their approval of the 2021 Foundation Programme curriculum. And the aim, as you've already seen, is to help you transition from being a medical student to a professional practitioner. F1 enables you to begin to take responsibility for patient care and to build on skills that you learned at medical school. It also prepares you for practice as a fully registered doctor in the UK. You've already seen from Caroline, there's many people here to help, and I won't reiterate, but you'll find details of your supervisors from your administrator and also can be found on TURAS. Now, to ensure satisfactory progress in the workplace and the educational programme, you need to record evidence, and this needs to be recorded on TURAS e-portfolio. The only evidence that will be considered at RP is the evidence recorded on e-portfolio by 31st of May next year. So the first thing to do when you open up TURAS e-portfolio is to sign the 3 declarations. That allows you to advance and gain access to TURAS portfolio. There are 3 main groups of evidence that you need to build. You need to build evidence of safe practice, evidence of team working, and evidence of learning. And there are a number of tools of assessment that help us to do that. Supervised learning events, or SLEs, the placement supervision group, supervisors' reports help you demonstrate safe practice. Team assessment of behaviour helps you with team working, and attendance and recording of teaching sessions, core and non-core learning, helps you with your evidences of learning. I suppose most people will know about SLEs, and it comes in various different guises. There's the mini CEX, or the mini clinical encounter. There's the directly observed procedural skill, and there's case-based discussion. There's also a number of other reflection notes allied to learn and to leader. And as well as being taught, you need to demonstrate that you're a good clinical teacher by developing the clinical teacher tool. The question is often posed as to how many SLEs do I need? And the answer is that you must provide sufficient evidence to demonstrate coverage of the curriculum. There is no minimum number or mix of SLEs. The clinical parts of foundation programme capabilities are best served by providing evidence through SLEs, and also SLEs are useful for showing you as a good healthcare worker. Placement Supervision Group is feedback from senior healthcare professionals who are asked to comment about your clinical and professional practice. The members are identified by your supervisor, and this informs his or her end of placement report. This is a good opportunity for you to show excellence in your training. You need one satisfactory PSG per year, either in post 1 or post 2. Your supervisor's reports, you need 2 recorded meetings with your educational supervisor each post. Your induction, your first or induction meeting should take place within the first 4 weeks, and your final meeting should be for the purpose of completing your end of placement report, which must be acknowledged at TURAS by you. By the RP deadline, you need 3 combined supervisor end of placement reports, 2 of which must be satisfactory, including the final post. The final post report must be on TURAS and acknowledged by the RP deadline. Team assessment of behaviour involves you choosing or selecting 10 raters and a self-rating. You need a mix of assessors, and the details of who you need are on ePortfolio. Like the PSG, you need 1 of these per year, again either in post 1 or post 2. Your personal learning log or your teaching log requires you to gather 60 hours of learning over the course of the year. For core learning, this is a minimum of 30 hours. It can be up to 60 hours, but the absolute minimum of 30 hours needs to be shown. Non-core learning can count towards the 60 hours in total, but only up to a maximum of 30 hours. In essence, core learning is the delivered foundation education programme. The topics are chosen according to a nationally agreed syllabus. It is bleep-free. It should be recorded by you in ePortfolio under the category of core learning. It is mandatory, and if you're finding difficulty attending or getting away from your ward base, you must inform your foundation programme director early if possible. These sessions may be repeated at different times and different locations. In addition to the delivered foundation education programme, alternative learning, for example, e-learning mapped to missed topics, can be used as evidence. Also, hours from simulation sessions, and some regions include specific hours from induction. It does not include hours from ILS or ALS, does not include departmental teaching, and may be delivered by electronic means such as Microsoft Teams. Non-core learning, as we said, is mandatory if you've less than 60 hours of core learning recorded. This can include departmental teaching, meetings, grand rounds, M&Ms, journal clubs. This should be recorded on ePortfolio as non-core learning using the reflective log. It must incorporate learning from all posts, so not just one post, and across a breadth of medical specialties and not just a favoured single specialty. Non-core learning does not involve on-the-job learning, nor does it include external study leave. It does not include tasters or ILS or ALS. If you want to look and see what the list is, there are a list of inclusions, exclusions on the Scottish Foundations and the UK websites. Now, in terms of the curriculum, by the end of foundation training, you will have demonstrated that you have achieved each of the 3 high-level outcomes as set out in the curriculum. HLO 1 is about you as an accountable, capable and compassionate clinician. HLO 2 is about you as a valuable member of the healthcare team. And HLO 3 is about you as a professional responsible for your own practice and portfolio development. Each HLO is further expanded in a list of foundation professional capabilities, or FPCs. You can note from this slide that there are a total of 13 FPCs, and it is to each of these 13 FPCs that you must provide links for 100% coverage of the curriculum. The new curriculum has much more of a focus on mental health and social well-being than before. And in addition, you'll gain experience in a variety of different areas and settings: community or primary care, acute and chronic hospital environments, mental health settings over the 2 years of foundation. The new curriculum requires parity in terms of mental and physical health evidence. And an example is given here of FPC2, whereby you're commenting on the management of the acutely unwell patient. You can reference the physical health of the patient by choosing an SLE that describes the acute cardiovascular deterioration. You might also note that the patient became acutely confused, and so comment on the mental health aspect. For FPCs 1 to 5, it is expected that more than one SLE will be required to demonstrate competence. Now, in addition to 100% coverage, it's important to realise that there is a hierarchy of learning, and SLEs such as DUS are provided by observation is the highest form of evidence that you have participated in that. But it's also important to know that you need to use the range of the hierarchy of evidence, so learning and reflection should be included in the evidences that you bring forward. It's also important that you know what's expected under each foundation professional capability, and to do that, within TURAS, the face-based in TURAS, you choose the curriculum button that opens up view guidelines. If you do that, it takes you to each of the foundation professional capabilities. There's a button on the right-hand side that again opens up to the specific requirements for that particular domain. So for example, here if you choose FPC2, which is within HLO1, there are a number of mandatory requirements that particularly devolve on the management of acute cardiopulmonary resuscitation. So it's important you know that and that you address that and you do the correct links. So it's only those pieces of evidence that you considered when reviewing the curriculum coverage that will be considered at RP. You need to ensure that the evidence that you link is relevant to the foundation professional capability and covers all of the requirements. So for example, you should be linking ILS to FPC2, and mental health evidence would also be linked to that particular discipline. The summary narrative is a relatively new development within the new curriculum, and you require one for each HLO over the year, so 3 in total. It can be up to 300 words each, and examples of what is required of you on the UK FPO website. It allows you to reflect on progress with curriculum evidencing. It allows you to explain the rationale for evidence selected to demonstrate each HLO. And it starts the process of your self-development to train for appraisal and revalidation. Quality improvement is an important part, and in fact it features in FPC 9. So you're expected to take an active part in processes to improve the quality of care. This, for example, the wording in FPC 9 is engages with QI initiatives through activities such as the collection of data for audit purposes, attending QI meetings, and following recommendations to improve quality of care. You also need to complete the GMC National Trainee Survey and the Scottish Trainee Survey. The STS comes out after each post. The NTS comes out yearly, usually in April or May. Other requirements include completed prescribing safety assessment uploaded to your TURAS, and you must ensure that FPC2 specific criteria are evidenced in F1. So the summary is that under RP requirements, by the 31st of May next year, you require 3 combined supervisor end of placement reports. You require a satisfactory TAB and PSG. You need a completed PSA. You need to have completed your 60 hours core and non-core learning. You need engagement with quality improvement. You need linkages to all aspects of the curriculum, including FPC2 specific cardiopulmonary arrest management. You need to have 3 summary narratives. You need to show engagement with the programme, and you need to have declared your absences. Question arises often about tasters. These are an opportunity for exposure to help guide career choice. You can take up to 2 specialties, a maximum of 5 days each. This should be within the region in most circumstances and certainly not overseas. It can be taken during the final post of F1 or more usually during F2. And the details of how to apply are on the Scottish Foundation School website. I think that concludes the presentation, and I think there's an opportunity for questions if Caroline's going to come up with here.
Thank you very much, Brian. That's very helpful. So, have we got some questions? Yes. So I'll let you sit down and then take the questions. So, Lisa.
The first question is, where can you find it for your clinical supervisors?
So you should know as you start your jobs who your clinical supervisors are, and the ward teams will be able to tell you. You will be allocated a clinical and educational supervisor. It should have happened already. The wards will tell you, and it will go upon to your ass as well.
And where will we get our computer logins and Ayrshire email address?
So these are tending towards health board type questions. They should be happening imminently this week before you actually fully start. So it should happen within the next 2-3 days. That's it? Okay. So if you have questions through the year, if you start to struggle, get in touch with us, your FPDs, your consortium leads, me. Because, as I've said before, the cut-off date, the one date you need to remember, the one exact time is midnight on the 31st of May. It needs to be all done by then. So please do not leave it all to the last minute. Right, I'm going to introduce Dr. Joseph Estran, who is our other own Tom Cruise. We've got 4 Tom Cruises. Dr. Joseph Estran is one of them. And he's one of our consortium leads. Thank you, Joseph.
Thank you very much, Caroline. So it's such a shame that you're not here and I can't see any of your faces or your reactions, because that's normally how I gauge how badly this is going or not. But anyway, so I'm Joseph Estran. I am a respiratory consultant at the Queen Elizabeth University Hospital, and I did not think I'd be here 30 years later as a consultant here when I came, just as you're about to start, having trained in London for what I thought would be a 6-month job in those days. It certainly wasn't as diverse as the intake of this 400 would seem to me. I can't see you, but I've seen some of the names. Some of them are almost as long as mine. It fills my heart with joy to see so many different people. I know 30 years ago, this talk about diversity, resilience and well-being didn't exist, but I'm also conscious now that it has become so common to talk about it that it's almost become like background noise. And I don't think this is something that is best delivered in a didactic lecture, so I'm not going to do it. I have one slide, and it's not Top Gun, much to Caroline's disappointment. I'm going to use this one slide to illustrate what I think is the journey of a doctor, and I'm going to use it as an example so that you can hopefully relax, sit back and enjoy this film. And you're not watching it because it'll be copyright. It's just a slide about which I'm going to talk about, and I'm going to describe the journey as a doctor using this as a parallel. Okay? So my one slide is The Lion King. I'm going to hopefully make that work. Is that projecting now? I'm not projecting now. Now you know why I went for one slide, right? Ah, beautiful, thank you. So I hope all of you have seen The Lion King. If not, forget Top Gun, this is the film to watch before you start work, because this will illustrate your whole medical career essentially. So let's start. For those who don't know the story, I'll go through it a little bit at a time. So it starts with the birth and celebration of Simba, the newborn, and the king to be. And that is you. That is each and every one of you, regardless of your gender, regardless of where you were born, regardless of where you were born, and every member of your family, your school, all those people celebrated when you got into medical school. That was the birth. That was success. You were there. You were the future. Now, having got into medical school, then in the early part of the film, it's all joyous, as I hope most of your medical school life was. Maybe a little bit of stress, wandering into territories that you shouldn't have done, as they do in the hyena land and everything else. But with the help of Nala, who's the other cub, he and she have adventures, and I hope you've had lots of them. At the end of medical school, which is where you're here, is when the film takes a little bit of a turn for a darker twist. Now, I know you're all in a happy place, I hope, all full of enthusiasm and hope for the year ahead, and I hope all the things we're going to do for you is going to support you. But it will be disingenuous of me to say if this year ahead was not going to be challenging. And so I'm going to show you what those challenges are in the film, so that when it happens to you, that you realize this is universal, that you're not alone, that it has happened before, will happen again, but where you can go to for help. All right, so the first of that journey in the film, if you remember, is actually the death of the king because of an accident. So when you're working in your first year, whether you're involved or peripherally or not, there will be death. And it may well be the first time that you're so close to death, and by some way or means you will feel upset, you may feel responsible, others may make you feel that it's your fault, as Scar does in this film, and you will find this a really challenging journey. It is really important to know that you're not alone, that although people around you on the ward round continue behaving as if it didn't matter and it was all part and parcel, and within you, you will feel I'm different from everyone else, you have to remember that you are in good company. So how does Simba in the film cope with it? Well, he runs away from it. He runs away and lives with friends that are different, friends that are not destined to be king, friends that are enjoying life. And I think that's an important part of your life too. You do need non-medical company. You do need friends and family out with the world of medicine to see that there is life out with work, and you must find some well-being with that support and separation from the stresses and strains from work. Now later on at the end of foundation, you might think the way to cope with this is to go to Australia. I know you will. I'm not putting you off that, it might well be. But it is a way of escaping from the challenges, but ultimately you do have to find ways of coping and dealing with those challenges. And if you remember, after some time and growth and maturity, when the world left behind, the lion pack and the lion kingdom has deteriorated, Nala finds Simba and brings him back. And that is the world of the NHS just now. It's not a happy place. It's full of staff that are post-COVID struggling. There's lots of gaps in nursing staff, in terms of medical staff, in terms of resource. It's really challenging environment. And you are going into it with hope, but there will be unkindnesses. It will not be directed towards you necessarily, but it can be. And it might simply be that people like Star, like the Hyenas, are in a dark place and they do treat you badly. And eventually you do have to find ways of changing that environment and changing the surroundings and engaging with a wider group to try and find some solutions for it. I don't know why all my slides are it's only my slides that are changing. So, in answer to that, to deal with that and to come through it in one piece, you need some support. And that's where both the support of the foundation team in the shape of Rafiki and Zazu is the bird is where it comes. Now, Caroline doesn't like being Rafiki, but you know, it's she and the rest of the team in foundation are just that. We're here to listen, we're here to guide you and to support you through change. Now, Zazu is really part of the support network, but it doesn't always seem like that. Why haven't you done your portfolio? You're missing a set of tabs. All of these things can end up you thinking and feeling this is just noise, it's not winding me up. I've got so much more important things to do. I don't need to listen to this noise. But I remind you, the main reason for Zazu being there is to look after you and to guide you and to make sure you get through this year and succeed. Okay? So, at the end of The Lion King, there is happiness. But that is a journey, and that is what I hope for you will happen. I have worked in healthcare for 30 years and I still love my job. Not every day, most days, I love it. There are moments where there have been snotters and tears, and probably more in my first year than ever after, but still there will be snotters and tears, and it's normal. But we are here, and your peers are there, and other wider team is there to support you. But it's important that you share. And it's important that you don't take this journey alone and feel that you're alone, because that's the greatest danger. Okay, so now, I am particularly invested in you lot this year, because I have to tell you that within your cohort of 400 is one of the loveliest people that I have known. My wife Katie told me not to embarrass her, so I won't. But she did grow up with my children, both of whom are slightly tricky boys, and she got them to school, went with them to school, same school, and looked after them for many years. So I'm incredibly invested in this person and you as a cohort, and we'll do our absolute best to look after you and ensure that you thrive in this year. So please come to us if there's any problems, any challenges, and we are here simply for that. Now, the one thing I do have to say, Beth, is that I'm dressed in this cycling gear because I encourage everyone to cycle, but in your case, we've got some knee protectors and elbow protectors if you're going to Dalbeatty, because, you know, I remember how you were on your bike when you were a kid. Okay, so with that final word, I hope and wish you all the best. There will be tricky times, but we're here, and please, please call any one of us if you need some support. Okay? Thank you for listening. I'll take questions, even if it's about the lycra.
So like a couple of questions, and it's regarding shadowing. So they're asking when will they find out when their shadowing shifts are, and will it still be available for those with a delayed start?
Okay, so the easy question first. Because there are 5 different regions, each local service has its own program for shadowing, and that will always happen for the straight starts. So what will happen is the first bit is always this afternoon will be the admin-y stuff, people asking about passwords and IDs and all of that. So all of that tends to happen It'll be different in each hospital, but it'll happen probably this afternoon. And then you've got a couple of days in which you're really sent to the ward that you work on, and you work with the team that are there. So they'll tell you the day-to-day practicalities of who the sick patients are, and who the grumpy consultant is, and all of those things. They'll give you all the low-down whispers. For the delayed starts, it's more challenging because they won't have the benefit of the outgoing cohort. So people who start a little bit later, make sure that the team on the floor know that you're starting a little bit later, and they will do induction in a slightly different way, in a more personalised way for you individually. But just make yourself known so that they can pick that up. Okay?
There's one more question I'm unsure if you've answered. When can we expect to receive our contracts?
That's a very good question. I don't know if I've ever signed a contract. I'm sure I have, but I don't know. But leave that question with us. We'll try and find an answer and get back to you, either by typing or something like that. Okay?
Yeah, again, that's a question more to be directed to the Health Board rather than to us. So, because we represent NEST, so we will try and find the answer. I think what we now have actually is a break in the programme. And we will be back online at 11 o'clock. So thank you for everyone for joining us. We've got a natural pause here, and we'll see you at 11 o'clock.
Thank you. I mean, I'm happy to chat, carry on chatting, but normally Caroline has to do that.
Well, that's a suspicion after the champion's jersey. Something you've done on
I bought it in the sale,
Okay, can you hear me from here, Ryan? You hearing that all good? Okay, so we've got mic down here. The only thing I can't hear is anything from the speakers in the room. Oh yeah, you won't have a mic up there, will you? Is the Teams call supposed to be coming out of the speakers in this room as well?
Yeah.
Okay.
One, not my one. Like,
Okay.
so once the room's on, you should hear Neil in the room, like just a normal Teams call.
Yep.
And I'm just going to screen record my second monitor, so that shouldn't interfere.
Brilliant. Yeah, fantastic. That works.
Right, I'll mute that.
And are you doing a
Yeah, I think we're going to do some.
also have programme W1. This half an hour is Neil and Manu talking about Surviving Foundation and a little bit about the Foundation Trainee Forum. What I would say to you is that West of Scotland's a very friendly place to work. We're all here to help you, so come and ask us if you've got any questions. Ask FY2s, ask any of the other trainees that you work with. And I'll introduce Neil first, and then I think Manu's coming in after. Hopefully.
Hello, hi.
Neil, are you on?
Yeah, I'm here.
Do you want to start?
Yeah, okay.
Go for
So,
it.
hi, I'm Neil. I'm one of the FY1s. I've just finished off working this year at Clyde Royal. I'm moving to Glasgow next for my GP. I've been asked to sort of do this very short presentation about tips and things I wish I would have known when I was starting FY1. I'm sort of doing half of the presentation and Manu's doing the rest, so I'll be as brief as I can. So I think I'm sort of focusing more on the practical things of FY1. And as a junior, you really need to have the sort of apps you need to navigate through hospital. And these apps on the screen are really your bread and butter, the ones that you're going to use every day. So MD Calc is one that you sort of use to calculate scores and things, so just things like CHADS-BASC and WELL score, things of that nature. So that's really good to have. The Induction app is an absolute necessity. It sort of acts like a switchboard. It gives you the extension numbers to everything that you might need. So that's really good. Talkspace is pretty good. I've only used it a couple of times. But for example, once I was called because a nurse had dispensed, I think 10 times the amount of Parkinson meds. And, I had very little knowledge about what to do outside of sort of the usual A to E. And Talkspace really came in and helped me there. It sort of gives you everything that you need. So BNF, sort of typical, you'll never stop using BNF. There's so many drugs, so many doses and side effects and things, so you'll never really stop using the BNF. It's very good. GGC Medicines is also one you guys already probably have. It just tells you things about management and things, which is really good because it's very hard to know everything, and the guidelines are up to date on things, so that's very good. GP Antibiotics is good for those of you that have your GP block. I put this in just because I'm having a look at it now because I'm in GP next, so that'll be really good to know. Geeky Medics is sort of, it's good in that sort of before procedures that you haven't done in a while, it's good to have a look at them. For example, I often use it for things like LPs and stuff. If I haven't done one in a while, I'll have a look, I'll have a read before, and sort of go through it slowly before actually carrying it out. So that's quite good. So those are the apps that you really need, and you use every day pretty much. So I think we can move on to the next slide. So portfolio, so the picture there is sort of the really generic stuff you use for surgery, because I'm going to apply for surgery, but it's very sort of generic in that all of the applications are quite similar. they require similar things. But if you're not sort of sure what you need for your application, things like MedBuddy, MedProject Hub, a very good forum as well on Reddit, Junior Doctors UK on Reddit is really good. If you have any questions and things, people there are really happy to answer them. And oftentimes, sort of people, junior doctors are in the same situation, so they'll ask the same questions you are, so it's very good to learn. So I think in general, sort of, they often require very similar things, like I'm saying. So things like sort of exams, depending on what specialty you're applying to. I think, passing your exams will score you points on your application. So attending courses, conferences, things of that nature, so electives. Taster weeks are really good to do as well. You can start doing taster weeks from the, I think, end of your FY1, so last block FY1. You can take a taster week then. I took mine in vascular surgery at the QE, which was very, very good. So I definitely recommend taster weeks for those of you that are interested. And then other sort of generic stuff like prizes. These can be like prizes in med school or prizes if you give a presentation in conferences, things of that nature. Postgrad qualifications are sort of, they're a bit hard to get in that you'll only have a postgrad qualification if you've done like a master's or a PhD, which is unlikely at our stage. But if you've sort of done something before and then come into medicine, that will count for a good amount of points. So that's something to keep in mind. Quality improvement projects and audits, they're really good. They're not compulsory for FY1, I don't think. But I think you need to do one for FY2 anyway. So I think it's good to just get it out of the way, start doing one in FY1. It'll count towards your application anyway. And then, either do another one in FY2 or just sort of keep doing the same one and repeating the cycles and things. But those are really good. They score a lot of points on your portfolio. So those are very good. Teaching experience is a big thing on portfolios. I'm pretty sure like most of the portfolios really focus on teaching. I think the move now is sort of moving away from simply just teaching medical students and other foundation year doctors to sort of organizing teaching as well. So this year, I think it changed this year for the surgical application in that you score the most points if you both organize the teaching and deliver it. So you don't just sort of show up and deliver the teaching, but you're also organizing it. And different applications will require different minimum of teaching. For example, for surgery, it's 4 teaching sessions, which is not a lot, but organizing it can take some time. So really think early with all of these. Really, posters and oral presentations. So posters, if you've done sort of like a case study or research, or any other presentation, even something like this will count as a presentation. Any sort of medical related presentation will really count. Publication is the same as sort of case studies. Getting involved in research, the better the evidence is. Case study is obviously the worst evidence, but it's the easiest to do alone. But if you get involved early, ask around sort of what type of research and stuff is going on, and try and get involved as much as you can. The earlier, the better. The leadership, I think, is probably one of the harder ones to get. You really need to sort of try and focus earlier on getting this. But I'll get to this on my next slide, which will explain sort of leadership. It's hard in that you really need to sort of think about it early, because it often needs to be for a set amount of time. It varies, but often the minimum is probably 6 months. But it's really good to have. It scores points on every specialty application. So one of the things I really wanted to speak to you about is the West of Scotland Foundation Forum. which is the sort of forum that's asked me to speak today. So it's sort of a recently set up regional foundation forum. It's basically made up of foundation year doctors who are representatives sort of their own hospital, and they take feedback and relay issues that their colleagues in that hospital are experiencing, and they relay it onto the forum, which happens every sort of 6 to 8 weeks. And then things like sort of rota, people not getting their leave, rota issues. Other than that, sort of working too much, pay, teaching, are they getting enough teaching? Is the teaching of good quality? Issues with ARCP is really good as well, and sort of overall well-being of doctors as well. And then you sort of liaise back what you've said in the forum and what the outcome of that was with your colleagues in that hospital. And sort of you form this channel, which is really good to have. So if you'd like to know more about that, or sort of that's something that interests you, that will be a leadership role as well. So the contact email for that, I don't have that on the slides, but the email is fairly easy to remember. It's foundation.forum.west@gmail.com. So that's very easy to remember, and it's really good to get involved with things like this, especially nowadays. It's really good to sort of get involved and sort of try and help with the well-being, both of yourselves and your colleagues, because you're all in this together. So it's very good. It's very good to have. So I wanted to just sort of speak about the don'ts about sort of starting FY1. So I don't know what Manu will speak to you about. So hopefully you don't laugh a lot. But what I thought would be really good to do is sort of go through the don'ts, mistakes that I've made, and mistakes that my colleagues have made in the past. And sort of we brainstormed together, and we came up with a list of don'ts that we wish we were told more explicitly when we started. It would have saved us a lot of sort of hassle. So we sort of brainstormed a list together. So I'll just go through that briefly. It'll only take sort of 2 or 3 minutes. But community prescription is probably one of the more common ones. You can't really community prescribe as an FY1. Oftentimes nurses will come up to you and they don't know you're an FY1. And they think you're an FY2 or above, so they ask you to sort of sign like a community prescription sheet, and you really can't be doing that in FY1. Same goes, like similar concept with DNA, CPRs, AWIs, things of that nature. The really formal official stuff we can't really do as FY1s. That's because you need the full GMC license to do all of that. So you can't really prescribe. We can prescribe other than the basics, but it's really not recommended because I know of a story, not in the UK, but sort of back home, an FY1 sort of would go around and prescribe medications that you really shouldn't be prescribing as FY1s, like things like SSRIs, things like, anything else other than the basics. So, electrolyte replacement and IV fluids would be probably considered the basics. So prescribing anything other than that, I'd probably run it by seniors. I wouldn't prescribe it myself. Same goes with making big sort of management decisions. Things like ordering, CTs or ordering stuff like OGDs for patients. You really won't be doing that as an FY1. The only thing you really be ordering and stuff routinely is bloods. Other than that, I'd really wait for a senior or a consultant to sort of outline the management plan and then just carry that out yourself. Breaking bad news is an iffy one. Some people are more comfortable breaking bad news than others. So it really depends, and really depends on the news as well. Some news hits harder than others. And I'd always run it by a senior. If you're wanting sort of more experience in that and stuff, I'd probably run it by a senior first. One of the more common ones, sort of on the same note, is talking to a family without patient consent. I saw this a lot when I started, and I wouldn't say it's the norm, but I feel like people do it, and we really shouldn't. So talking to like a family comes in and they just want an update, and you let them know what's going on with their dad or the mom, and we really shouldn't be doing that, sort of, because we really need explicit patient consent to be doing things like that. So I'd probably just ask the patient first if he's okay or she's okay with us speaking to their family before doing that. Something you're going to be doing a lot, bloods and cannulas. I probably wouldn't try more than 3 times. I think 3 times would probably be the maximum amount. It's not the nicest thing to do to patients, and oftentimes all you need is like a new, fresh set pair of eyes will sort of help you with that. Patient names on anything other than sort of like an official NHS Outlook email is very, very frowned upon and really shouldn't be done. So even things like WhatsApp, there was a common misconception with WhatsApp, I think, because people thought it was encrypted and things. You can use patient names, but you really can't. I'd only use patient names if I'm sort of referring someone via NHS Outlook email. Other than that, I just wouldn't. It's just not done. Documentation as well is very important. I feel like one of the things I really struggled to get when I started FY1 was if it's not documented, then it just didn't happen. So if you update a family, or they said they're fine with that, or even if it went well, because oftentimes people document when things go bad, but it's really good to document even when things go well, because you never know. So it's really good to sort of keep meticulous account of what happened and always document even when things go well. I think the last one I'll leave you with is a very practical one, one that I did myself, so I'm speaking from experience, is requesting bloods before you go home for the next day. There was one day where I just forgot to request the next day's bloods, and I spent a fair amount of time the next day just bleeding everyone. So I'd really recommend you don't do that, and request bloods every day for the patients that need them. But if you have any other questions or I've missed anything, I'm sure Manu will go over the rest. But if you have any other questions, I'm more than happy to answer those.
There are a couple of questions. Will we take them now?
And that sounds like a cue for me to come in. So hey everyone, it's a bit weird at the moment because I'm currently sat in my car in Torridon, so I can't actually see anyone. But I'm Manny. I'm currently in F1, but come next week, it's like Christmas comes early. I grow up and I become a big boy, and I can start doing AWIs, DNA CPRs and things like that. And I'm just going to cover a few other things. So mine's going to be a bit more generic, just sort of general advice. We've got 12 minutes, so we'll bash through it, and hopefully you'll gain something from it. So I can get the next slide. So, plan for what we're going to do. I'll have a quick chat about ARC-P. Effectively, think about ARC-P as like your end-of-term report card. So when you finish your F1, and then again when you finish your F2, it's a whole sort of tick box exercise to say that you've done a certain amount of things, you've experienced stuff, you've seen stuff, you've done stuff. And if that's all a tick, then they're like, great, you can be an FT. So let's run through that, because in reality, the important thing in F1 is making sure you've got that all sorted, because then that will be so much less stress come the end of it. Then I'm going to cover a few other things, kind of like Neil did, just things that I wish I knew, kind of reflecting on the past year, what I was like, I probably could have done that better, or I wish someone had told me that before I started. And obviously, as always, if there are any issues, any questions, just get in touch, ask us. We're relatively friendly. If I can get the next slide. So, ARC-P will become your life at certain points. So that's done through Curas. I've got the lovely home page here. If we go to the next slide. Then you see where you go to start updating stuff. So your ARC-P is your annual review of competence progression. And like I said, it's kind of just like an end. So it's just saying I have achieved everything I need to in F1. I'm a safe doctor, and I have the necessary experience to move on to FY2. So if I go to the next slide, you can see that you can update lots of evidence and things. So on the previous one, you had the little drop down where you could choose different things, and the way you evidence your experience are through these things called supervised learning events. Now, it's all very fancy words, so I'm sure it's all very important, but effectively, SLEs are just stuff. And through the year, you do stuff, and that stuff shows that you're going to be a good doctor. And those SLEs, they're split up into different types. So you've got CBDs, which are case-based discussions. Think of that as discussing a case with someone. You're chatting about things, you're talking about how you would manage it, but you're not necessarily doing anything. Now, you might chat about something that you have done, but in terms of evidence, it's kind of like a talking sort of thing. You've got adopts, which is where you've done an active procedure. So like Neil mentioned, things like LPs or maybe assisted taps, stuff like that. That would be adopts. Things like bloods and things probably don't count, just because they're not that level of procedural skill. If anything that you need to stay sterile for, you can probably count that. That's kind of my rough and ready way of judging it. You then have DCTs, that's a teaching sort of thing, and you're supposed to aim to get one of those each block, or maybe for block 1 and 2, because your RP happens halfway through block 3. The best way of doing that is if your department does any departmental teaching, or if there's anything you can get involved with, get a registrar or even just some senior to be there, and then they can sign you off for it. And it also looks quite good as you go forward for applications and things. And then the last one's a biggie, it's your mini texts, and that's your doing. So that's when someone has watched you or knows of you doing something. So whether that's breaking bad news, if it's you doing procedure, if it's you managing, a crash call, something like that. If you ask someone to evidence that, that is you showing that you can actively do something. So it's the highest level of evidence. And what you want to do with these is you want to link them to the different capabilities, the FPCs that come with the course. And as well as trying to get these early, because the kind of rough guide is to aim to get 5 in each block, so block 1, block 2, block 3. Obviously, if you can get more, that's great. And my big tip for that is just to start getting them early. Just whatever you do, ask someone. If there's Reds with you, an F2 with you, whatever, just be like, oh, do you mind signing me off for that? Do you mind just, if I send you a ticket for whatever I've just done, they'll almost always be like, yes. But also make sure you link it early, because otherwise you get to a point where you've got, 20 odd SLEs, and then you're like, oh, damn, I need to go back through and link them all to the stuff, and it takes like 2 hours. So just do it as you go, and it will make life a whole lot easier, and do it early. And if we go to the next slide. So that's your SLEs, that's your stuff. You then have how you work in a team, and that's effectively don't be a dick. The way I think about it is, part of F1 is showing that you have the ability to do it, part of it is showing that you're actually nice to work with, because medicine is all teamwork. So your tab, you only need to do it in one of your blocks, and generally the easiest way of doing it is to do it in your first block. You create a self-tab, which is the button you can see there, which is where you say, oh, these are what I think my strengths and my weaknesses are, and there are little boxes that you can fill. And then you create tickets, you ask people if you can send it to them, get their email, and then you send it. And they kind of go through those. They don't see your answers, but they can write their impression of you in. Almost always people don't have concerns. If they do, they can flag it up, and then you can chat about it with your FPD. And it's not like a telling off sort of thing. It's more of a, oh, we've identified that this is something we can work on. How can I help you with that? The key with this is that in reality, you need to get 10. But in reality, you need to send out 20 or 25 to get 10 responses. Because for every person who you give a ticket to, someone else you're going to give a ticket to, and it will disappear into the ether, or they'll just be too busy. So send them all out. Try and do it in your first block because it makes life easier, and you need a certain split of people. So I think it's 2 consultants. You can have a max of 2 junior doctors, F1s and F2s. You can get pharmacists in, you can get auxiliaries in. Effectively, just find your team, be nice to them, which you should always be, and then go from there. And if I can have the next slide. So that's the breakdown on your MDT of how your tabs will go out. I think this is my one. So as you can see, just a bit of a random spread. Clearly the pharmacists don't like me because no one gave me one. And next slide. So the way I thought of things is think of it as a tick box. Think about what you need to do and try and get it done. So if this, for example, for your first block would be what you need to do, you meet your foundation program director once. You'd want to meet your supervisor. You get told who that is. You want to do that 3 times. So one at the start, one in the middle, one at the end. The one at the start is to say this is what we're aiming to do. The one in the middle is to say are we making progress. The one at the end is to say we did what we said that we would do. SLEs we've talked about, tabs we've talked about. You can do some reflections. They're quite easy with the lowest level of evidence. So just pops them in. And then your core and non-core learning, we'll touch on it in a second, but you need to get 30 hours of each. So a total of 60. So just try and keep that ticking along. It can be really, really difficult when you're on the wards because it can be really busy. But ideally, you do want to have an hour a week to be able to get through that. So if we tick on, hopefully something will come up on the other side. Oh, got a dramatic pause. There we go. So then you can go through, and if you have it kind of as a checklist in your mind, as you go through the block, you can figure out what you've done and what you need to do, and you can make sure you're on track. And those 2 little extras that I put in there, the QI is a quality improvement project, and you just need to show involvement in it for your F1. So if you do your NTS, or National Teaching Surveys, or your GMC surveys, equally like Neil said, there's a foundation for it, being involved with things like that counts. And obviously if you do projects and audits or whatever on your ward, that will count. But the bare minimum is just filling in those surveys just to show that you've been involved in it. And when you get to F2, you then have to actually have your own project. The ILS, hopefully you'll do it in your induction, but you want to be able to show that and make sure you save your certificate because that evidence is HLO2 and it's one of the things you need for your RP. Next slide. So core, non-core teaching. The core stuff's pretty easy, just because you dip it on teaching, you watch the teaching, bish bash bosh. Non-core teaching, it can feel like a bit of a drag, but I would view it as like an opportunity just to explore what you're interested in. So for me, I quite like emergency medicine, I quite like peds. So my first job was peds surgery, so I did a lot of the departmental teaching there, a lot of the neonatal X-ray meetings. Some of the grand rounds are quite interesting for the stuff that I like. And quite often you can get away with doing things that you want to do for your own progression and then saying it's non-core teaching. So level 3 child protection for me is something that on the person spec for PEDS training you need to have. So you do that training, you can then log it as non-core teaching, but you would be doing it anyway. And then the other thing I'd say is podcasts, because they can be a bit more digestible, it can be a bit more fun. I used to Glasgow series halfway through my night shifts because I don't like sleeping on nights because it messes up my sleep pattern. So little things like that can always help. Next slide. And then that's just an example of the different things that I ended up doing. Next slide. So then we get to the fun bit, which are my little tips and tricks. I'm aware I've got 2 minutes because I like talking a lot, so I'm going to smash through this. The most important thing, look after yourself. You can't look after other people if you're not looking after yourself. So simple things, I'm going to sound like your mum, but making sure you sleep, making sure you eat, super important. Having someone to talk to is also really, really key, whether that's your colleagues on your ward, if it's friends outside of medicine, but just making sure you have someone to offload to, because we do have a pretty difficult job, and it's something that can emotionally and physically take it out of you, so that's important. Next one. I think this is really important, so make sure you keep doing stuff outside of medicine, because if your entire life is medicine, that gets a little bit sad. So I like playing lacrosse, I like walking up big hills. I can see a big hill I'm about to run up. Once I finish the presentation, keep doing it as best as you can. It's difficult with time, you will miss stuff, but try your best. Next one. So I put this in just because it's a big thing, especially with juniors, but for everyone, where if you're sick, if you're tired, you feel like you need to go in, especially when it's super short-staffed. But if it's a legitimate reason, you can just say, you know what, I'm not going to come in. And also, when you're on the ward, it's super important to have breaks. So always have lunch, always make sure you're eating, always make sure you're drinking and staying hydrated. If no one else, do it for me. Next one. And just to say, I'm not here to bullshit you, and I'm not here to be like F1 is all sunshine and roses. There will be parts which are really, really hard. There'll be points where the workload feels unmanageable, and where the ward's really busy, people are really, really sick, you're really stressed. There'll be points where you miss stuff you really want to do. I've had it where I've had dates planned with my girlfriend, and then someone calls me and is like, guess what, you're on a long shift now. Or I missed my graduation because I was scheduled to work and I couldn't swap with anyone. It sucks. But, and if we go to the next point, we're all in it together, and there are really, really good points, and when you make someone's life better, that's what we're all in it for. And you will have really, really massive highs as well as the big lows. So when you're in a rough point, and when you're like, oh god, this sucks, why did I choose to be a doctor? Remember that it is actually a really, really great job, and you're doing great things. Next slide. And we can just whack through these. Things I wish I knew. People can be arseholes, and if we just flick through, that can be anyone. So consultants can be mean. That happens. Normally they're not, but sometimes they can be. Next one. Sometimes it can be the nurses, especially because they're overworked, they're stressed. Sometimes they don't really understand what you can and can't do. It can be really annoying. The job can be really annoying. But the most important thing, if we go to the next one, is that we can be assholes, because assholery is indiscriminate. So the biggest thing is just to try to be nice, because if you're nice to people, they'll be nice to you, and if we're all nice, it makes the job a lot easier. Next slide. I'm big on this. There's a big culture of staying really, really late and picking up extra shifts because you feel like you have to. Make sure you look after yourself. One of the really good sort of resources for this would be the BMA, because they tell you kind of the rules in your contract for things like when you're contractually obliged to cover and when you're not. So keep an eye on that, be aware of it, and check out the BME pages for stuff like covering people's short-term absences. Next one. Get to know your hospital. So in your shadowing period, which I'm hoping you're all doing, talk to your F2s, figure out stuff like parking, where the best coffee shops are, in the QEH, aroma over CPGs, super spenny. Little things like that, it makes your life so much easier. The acronyms around hospitals are an absolute nightmare, so just use your F2, the current F1s who are going to become F2s, because they are the ones who have just been through it. We're pretty much the same as you guys, just a year more senior technically, but actually we're all the same. So get to know the little tips and tricks from them that will help you for your job. So track care shortcuts, like the anti-bio, when you type it into the little blood search box, it will save you so much time. Figuring out, like Neil said, how to request bloods in advance saves you so much time. It's those little things that make all the difference. Next slide. I'm going to finish this almost on time. Like Dr. Uman said, always ask, because everyone's super nice. Even if someone's stressed and they've been a dick to you on one day, they might have a better night's sleep, or just, have had a coffee, and actually they'll feel really bad about it. So, if it is that RC consultant, or if it's a reg who looks really, really mean, or if it's a scary F2 who's giving you a talk over Zoom and is, a bit annoying and talks a lot, if you're not sure about something, just ask us. And like Neil's been through, lots of the apps will be the answer to those questions. So, your Induction app, your GGC acute medicine app, the therapeutics app is also great for management. Just always be asking questions, and if someone tells you that it's a stupid question, then forget that, because there's no such thing. Next slide, which I think might be the last one. Beautiful. Remember that we're all pretty much the same. So FY2s and FY1s, literally the difference is one day. Like on the 2nd of August, I'm not able to do an AWI. On the 3rd of August, I can. It's kind of a bit of an arbitrary cut-off. And there'll be points where registrars, consultants make mistakes. There'll be points where you make mistakes. We're all part of a team. So if someone puts pressure on you or is mean to you, don't worry about it, because it's just because they're stressed and they're insecure as well. So all work together, and remember that, we're all here to make each other's lives easier. So don't be afraid to ask questions. Don't be afraid to ask for support. I had a moment a couple of weeks ago, which I was really, really happy with, where a consultant turned to me halfway through a really difficult decision about a patient, was like, what do you think? And I was like, I've had 1 year of experience, you've had 30. She was like, yeah, but I value your opinion and you've got a different perspective. And I think that's a really good attitude to have. No one's better than someone else. It's just people are different. And last slide, please. any issues, feel free to get in contact either with myself or with Neil. Always happy to help, always happy to, have a chat, whatever it's about. Hope it was useful. Sorry for going 5 minutes over. Enjoy Induction, and I hope that all the speeches haven't been too boring.
Thank you, Neil, and thank you, Manu. I'd just like to point out that I'm in Glasgow. Well, Neil is in the Lake District and Manu is in Fort William, so they're actually having a good time as foundation trainees. The only thing I had to update on Manu's slides was, as an FY1 now for QI, you should be doing a project as well as the GMC survey and the Scottish Trainee Survey, but you can chat to your FPDs about that. The other thing I just wanted to say, teaching is on every week for FY1, so please try and attend, if not just to get teaching, to have your lunch, to also meet other trainees in your hospital, and it's a good opportunity to meet each other. And I think we've got some questions. Oh, well, there is a email that we can give you. We can put it on the WhatsApp and also on whatever Michael's doing. Yeah, and you can get in touch with us. And the trainees usually look at the emails, and you have to put in a reason about why you want to join and which program you're in, and show interest, and then we take it from there. I suppose it depends what departments you work in, and might be who your supervisor is. It's worth chatting to your supervisor, worth chatting to your foundation program director, who might lead you in the right direction. Yes.
And we'll get a new point of contact every block station.
No, it changes every block.
Just wondering about working things. Is there any things that you may have?
Oh, for FY1? Health Board HR. Suppose you might want to find out more about the patient, so you might say, let me go and have a look at the notes and speak to the doctors that are looking after them, and then get back to you. Might be a good answer. Thank you, Neil and Manu, for doing that. Enjoy the rest of your holiday.
Thank you. Thanks for having me.
Thank you.
Take care.
Introduced, I will cover. Are we live again now? Thank you very much for that introduction, Liz. Liz and I know each other a long time. We used to share a foundation programme, and I've just been ignored by my colleague, but that's okay, I'll get over it, I think so. It's also slightly chilly in here. I don't know where you all live warm, but actually the air conditioning in the college is actually slightly cold. So I'm keeping my jacket on, and I'm taking a while to warm up, so it's a little bit colder in here as well. I hope you've not been too overwhelmed by everything that's been happening this morning. I'm just going to check that I can go backwards and forwards in the slides here. Apparently the talk, unless I get your attention in the first minute, then the rest of the next 20 minutes isn't really going to work. So actually something came through from the National Training Survey about some of the problems in our posts. And that triggered a deanery visit to a post, which will remain nameless for this, although it is publicly available domain. I thought I'd read you out something from this. This is directly from the NES visit to this training post. Said the panel heard of good relationships with nursing staff reported through WeCare. However, the foundation trainees report concerns around undermining on the ward, which was later supported by the senior cohort. Foundation trainees at times feel harshly treated by nursing staff who actively prevent them from attending teaching, do not value them as doctors in training, and often escalate matters within their competence above their head. So I think you probably heard from this morning about how you've had all the support mechanisms, and I know Lindsay Donson and Caroline and Joe we're talking about how there's a support network in place. And Lindsay, who's the Director of Medical Education, is also responsible for the Civility Saves Lives part of NHS GGC as well, for those of you in NHS GGC. And this, many of you will have heard the Civility Saves Lives talk before. If you've been through Glasgow P4P, etc., you've heard it. So I've used the original Civility Saves Lives talk, which you may have heard before. If you haven't, you probably will fairly shortly. Or if you haven't, you can actually see the original online. And I've modified it slightly with some other aspects of it. You've had lots of advice about how to live your life, and the only way you can live your life is find your own way to do it. I think you are at a difficult stage of your life. And somebody came up with this quote the other day, which I really like about being a junior doctor, is that you're slightly too old to party. You can't have the same hedonistic lifestyle that you had as a student. Days of nightclubbing and long nights don't really work with long shifts and long weeks, so you lose that part of your life. But equally, you're still young enough that you don't really want the lawnmower and the slippers and the comfortable life and going to bed early. So first of all, I think we have to acknowledge that's a difficult part of life for you as well. Part of the civility work really came about the appreciation about teamwork. And, oh wait, we've gone way fast here. Wow, that's really fast. Is someone doing this deliberately to try and speed me up? I feel like I'm being controlled by outside, in case I say anything else dangerous. So I'm a big rugby fan, and the All Blacks are a great example. If anyone wants to read about teamwork, the All Blacks have written a book called Legacy, where they had a psychologist working with the team for a year to what they did. And the biggest thing that came out of that for me was humility. And there's a great story about the All Blacks after winning a championship big match. They have a big party in the changing rooms afterwards, and they're celebrating quite happily, quite loudly, quite raucously. But at the end of it, some of the younger ones who haven't been in the team before are about to leave, and they get tapped on the shoulder by Richie McCaw, who's a complete legend of leadership, and says, sorry, we haven't tidied up yet. And you have to tidy up. It's called sweep the sheds. Whatever you do, however successful you are, you have to tidy up. And that's the same in our workplace as well. Offer to make people cups of tea was one of the suggestions made. Again, offer to tidy up. Clean up your own mess as well. Don't expect everyone else to do things for you, however important you think you are. Still remember the day a professor made me a cup of tea and washed up afterwards when I was a trainee. So, this is really somebody's got some control going out. Or was it just my tremor? The cold is so cold here that I'm actually now shaking as well with this. So, teams matter because of all these reasons. Everyone shows that when you have a good team, everything works better. And I'm not going to go over these points as well because I need to get into the sunshine and warm up as well. The Civility Saves Lives thing has this nice picture as well. It's like 3 steps back, 2 forward. Nothing. The people at the back are just waving at me saying it's not them, and now I've lost everything completely. Wow, this is all really going pear-shaped. Now someone's controlling my world. There you go. All right, shall I dare risk one back? Okay, so this is the slide that comes up. Good teams save lives, and this is the slide that comes up. Well, I'd just like to point out, if you ever see this slide, this teamwork is not allowed. There's a level of contact, not allowed anymore. The watches, the jewellery, the below sleeves things, you're not allowed to use that. So this example of teamwork is pretty bad. Right, I'm going to try next. Do you want to do the next slide for me? Is that easier? No, that's not working either. Okay, I'll try once more. Okay. Part of this work arose from studies about simulation. So this is where this all comes from. And if you read the Civility Saves Lives website and the people who do the talks on it, it really comes up to one issue about what happened in a simulated scenario where they had a surgeon and an anaesthetist, and they did a trial with 2 episodes where, in order to respond to a crisis, they had the surgeon who was rude and they had the surgeon who was polite. And they found the anaesthetic performance was significantly different based on how that surgeon performed. Right? So that got people interested, okay? If your performance depends on how other people treat you, that's an interesting phenomenon, and it proved it really for the first time in a sort of simulation setting. Right, I'm going to go again, one more slide, here we go. I don't really like this slide research that much, and it was uncomfortable for me a while, and I've been thinking quite hard about why it's uncomfortable. One, I think it demonises one poor performing doctor, and it makes the other a victim, and I think that's a very difficult relation to always have. I think it's slightly stereotypical in this sim. The rude doctor is a surgeon. It's also limited about what to do and help. I also have a slight issue in that people know that much research into psychology never gets reproduced that well. It's one of the biggest problems in psychology research is that much of it isn't reproducible, and it also has a few biases as well. So I don't really like the way that my pointer doesn't come, does it? I've drawn some horns on the kind of rude surgeon afterwards, because I don't really like that person being demonised in that way. And the reason I don't like that is for this next slide. Okay, so what if these things are going on for this person, or as I just discussed, they weren't allowed to go to their teaching, or something else happened? So I'm just going to let you read that list actually as well, rather than talking about it. These are all reasons why I think someone may perform in a way which you would not want to see from someone. So I think sometimes when this gets presented, it gets presented as people who have personality flaws, and I think often trying to understand the reasons why people have anger. And this is borrowed from my favourite source of self-help. It's an American called Brené Brown. This is her new book called Atlas of the Heart, where she talks about all the emotions. And if you see someone who's angry, then there's often a huge spiral of things that may be going on behind. And unless you understand or try to understand or work out what's happening with those, then I don't think we're all going to get very far. We'll end up just shouting at each other, which doesn't help either. Just a few more of the sort of slightly more corporate parts of it. Oh, hey. Is this you, Joe? Is this because you only had 2 slides? You're laughing at me now because you only had 2 slides. Look. What's going on? Ah, I'm getting waved at from the back. Okay. We're back on shape. That's just sort of stress tests me slightly more. Incivility is rude or unsociable speech or behaviour as interpreted by the recipient or third party. And we have a lot of conversations about that. Is it acceptable if someone has that behaviour if we're experiencing it? There are many examples of it, and you will come across many. I'm not going to go through all of the ones for time reasons at the moment, because I've got a couple of things to say as well at the end. What it does do is the effect it has is quite profound. So the research on this in the sim stuff shows... Next slide, you're going to do it for me, guys? See, even they can't do it. Even they're struggling. It's all going wrong. It's not me. I'm going to pray to the PowerPoint gods one more time. I've not sacrificed my firstborn child to the PowerPoint gods this morning. So the impact of rudeness has been measured. I think the most pertinent one at the moment that worries me the most at the bottom is kind of the 12% leave. And 25% take it out in the custom space, so it becomes a learned behaviour. So if you have an organisation where this becomes normal, then people who are the recipients of poor behaviour or bullying or incivility then start to exhibit that behaviour of bullying or poor performance as well in themselves. That's one of the problems that can happen. Can I have the next slide, please? And it also affects people around as well. So this has been done as part of sim stuff as well, that other people start to get affected. So they've looked at people who are in that simulation. The other people involved who witness the uncivil or bullying behaviour also start to perform less well. Presumably, they've got increased cognitive load. They've got some worrying going on about what they've just seen. They don't know how to react. The emotional state goes up. Cognitive performance goes down as well. And 50% reduction in willingness to help others as well. So they become afraid to speak out as well. Once they've witnessed it once, and it's seen as okay, then everyone has less ability to do it as well. Okay, and the next slide as well. Oh, it's doing 3 at a time, isn't it? It's like 3 steps back, 3 steps forward, and 2 steps back, which feels a bit like British politics at the moment with the Tory leadership debate, doesn't it? You're never quite sure where they're going. And also, other people who notice this as well, patients or relatives, feel less enthusiastic with the organisation and anxious dealing with staff as well. So everyone seems to get affected in more ways than we think. Okay. Right, can I try the next one? Should be anyone who's got sort of any problems focusing. So this is the standard model that comes up in the civility slide, which is a civil clinician, bad things happen, gets allowed to happen, they become an incivil clinician. I think that's slightly simplistic and also one way I think probably most of us flip between that slightly. All of us have different stages in that as well. We all start off trying to be the person in green, and sometimes we all have our slightly worse moments where we're less kind or less considerate than we would like to be. And certainly I was receiving yesterday, at the end of the shift, I'm not as tolerant, I'm not as nice as I could be. And at the start of the shift, when I'm anxious about how it's all going to go, that's probably not a good time for me as well. And in the middle, I'm a bit tired and grumpy, so actually maybe yesterday was a bad example. But it changes on how you go in time to time as well. But equally, all of us can't say we're all perfect all the time and they're all incivil all the time. I think there's a fluctuation in what we see as well. Importantly, I think the next slide, if it gets one to work, this is just something that came out recently as well. You've heard quite a lot about how organisations are designed to help you. So can I try the next one, please? Should get me to the BBC slide. That one's stuck in a nice way. Thanks, guys. We've got this sorted now as well. If any of you haven't heard about the NHS Highland bullying report, I think it's well worth a read. You can Google it and find it yourselves. There was a culture whereby the organisation was seen to put significant amounts of pressure and undermining that led to a high-level inquiry, and they've now paid out £3.4 million in terms of settlements to staff as a result of bullying. That was an organisational culture that came from all levels of the organisation. So I think for the organisation to say, don't be uncivil, is difficult as well when we know that's happening within the organisation and some of the things you get asked to do as well. So I'm going to show you one example from this. This is with permission my next thing. So we've got 10 minutes to go. How are we doing? We're okay. I tried to find some real examples. I think some of the tips from the last two trainees were fantastic. I know they're probably running up their hill by now and having a great time. But I wanted to show you some of the other reality of one of the trainees that emailed me with something last week as well. So get the next one, thanks. So this is a trainee who's in his third block of F1. He had made a swap as part of the original part of the rota, but unbeknown to him, and all that had been agreed at the time, and he had it for a very specific reason, as you can see in the slide. Unbeknown to him, that hadn't filtered through to the medical rota people. And at the start of the week, on the Monday, the new rota came out and it had him working the weekend. And he was slightly confused because the overall planner said he wasn't meant to work the weekend. And he clearly had made significant arrangements for that weekend that then caused him quite a lot of anxiety. He said, I can't really, my grandmother's coming, she can't navigate on her own, how am I going to manage all of this as well? So he wrote what I thought was quite a nice, sensitive email to the, I've outed the medical rota team, sorry, rather than the surgical rota team. I should have kept that anonymised, but didn't realise it outed the medical rota team. So this is, I'll show you the email he got back from the rota administrators, which is the next one. So. Now the problem with that email for me, and I read it, and it was difficult when we get these stories from trainees about where do you sense the problem lies, and half the time you're never quite sure where the problem lies or whose fault it is or what the reality is. But what struck me about that email for him was the complete lack of empathy. Yeah, he'd written quite an emotional, empathic email with understanding, and the email that he got back was, tried to phone you yesterday regarding this. His email afterwards said, well actually, I wasn't working. But just tried to phone you. There's no empathy for, yeah, we understand this is a difficult situation, or how can we help, or anything else. And somebody else just said, that's it. And yeah, that was left as pretty much left to him to say, this email says, I've got really no care about you as a person, or no care about your grandmother, or anything else what you're doing. And he's in bits, because this is what he's been told to do, this is what he's trying to do. So he's now caught between these two stools of saying, I've got to disappoint someone massively about not coming over, or I've got to work out the rota. So that was really difficult. Fortunately, with a bit of help, we resolved it, but only when the medical rota people had to go back another day later and realise that they had made a mistake and it wasn't meant to be him working this weekend. But the poor trainee had 3 days of stressing about what was going to happen. And I think that's another example of the incivility that you will come across. There's no sugarcoating this. There will be some incidents like this where the organisation will put you under stress in that sort of sense. Yeah, there's nothing very cuddly or nice in that email, I didn't think. So. Okay, so what can we do? I'll go back to the slightly more corporate bits. Oh, it's gone again. It's going mad. I don't like this. In fact, you're getting a flash preview of the slides ahead. This is like you now know there's a cow coming next, but you don't know what the cow's going to mean. So the official line on this is that you should monitor your own rudeness, which again is really difficult. I don't know whether I'm being rude or not. You know, we've already shown that the research says you don't know whether you're being rude or not. You don't know whether you've been affected by rudeness or not. Foster politeness and kindness. I think we can do that. Again, if nothing else, be kind. Call it out with care is difficult. So how do you deal with those situations? It's the same as microaggressions, or the same problem if you notice racist behaviour or sexist behaviour or any other behaviour which is unwarranted. Having the ability to call it out, particularly when you're at an early stage of your training. I find it really difficult now, and I'm probably old enough and big enough not to care too much. But I think at your stage of training, that is really difficult how you do, and you may need support to do that. And again, going back to things like Joe's talking about, that's what we're here to help you with as well. So, create a culture that rewards these. Well, that's something NHS Highland didn't do. Well, then the rewarded that is now 3.8 million, which is probably going up to over 5 million from what I understand for payouts for bullying for them. So, okay, can we try the next cow slide, please? There you go. There's a cow. I don't know why I picked a cow, really. I don't know. I was trying to think of Joe's talk. I knew Joe would have some great slides, so I wanted a cow. I thought a cow is quite a good example for an FY1. I think most of the time you have to be fairly placid, chew your grass, get along with things, but cows have horns for a reason, right? And you do occasionally need to use your horns. So I thought this is how you should view your foundation program directors. They're for you, happy, but we have some horns occasionally to help you as well. Most of it is because we can't protect you from incivility. And the last question was something about dealing with a family and talking to someone who's got an unconscious relative. That may be a really difficult situation. They may be hostile to you. That's not going to go away. You can't suddenly say, sorry, no incivility here, not allowed. That may happen, and you may have to deal with it, but you may need help with it, and that's really what we're here to help you with. We're not going to pretend everything's going to be fine, but we will be there with you when the bad things happen as well. Okay, can I try the next one, please? My only other worry about lowering incivility is that I think there are times when it's appropriate to raise concerns. And I think we have to get this balance right of how you raise a concern about when something isn't right and things are unsafe, and you're all going to go into rota gaps, and you're all going to find nursing shortages. Those of you who saw any of the BBC stuff on the weekend, QEH running with one trained nurse per ward at the weekend. You need 2 people to sign controlled drugs. So there's issues like that. We have to be able to speak up about some of these issues as well, because if you don't speak up about them and everything is suppressed, you're just told it's uncivil. And that level of suppression still happens. So I was talking to some colleagues who were doing a significant event review about something that happened in one of the wards, and they weren't allowed to mention the staffing levels in that ward. It wasn't part of the review process. And they didn't have the confidence to inquire why that wasn't reasonable, because something bad had happened. It just seemed to be the corporate culture that we don't discuss that. If you ever want to see a really good incident report, it's a really tragic accident, look at the Clutha helicopter crash. The Clutha helicopter crash, I'm digressing mildly now, the Clutha helicopter crash details all the shifts that all the staff had done in the days before the incident, and how tired they were, where they had all the appropriate training, and why the helicopter might have crashed. We just say, on day X, Mrs. B got too much drug from Dr. X. And we don't really think about why. And I think we have to start raising those questions a little bit at the moment. So I think we should be more confident. We should be able to express those disagreements. So I think those horns are sometimes useful for a reason. I think you are allowed to release the inner bull sometimes as well. Okay, can I try the next one, please? We're nearly done. I think difficult conversations now, again, we've talked a lot about having... I was struck by the question that came up about dealing with the family who want to know what's happening with someone who's got a deteriorated level of consciousness. My answer to that is always, well, tell them the truth. That may be unpleasant for them to hear. It may not be what you want to say, but there's a great phrase that truth isn't like red wine. It doesn't get better with age. So whatever you do, be truthful, even if it's uncomfortable. And I think that then leads me to the next part of it, which is difficulty with trainees or colleagues. So the most difficult conversations I have, and I'd like to say welcome W31, I'm your foundation program director. I thought I'd say that a later rather than at the start, just to convince you I was okay, is when we have conversation with trainees who are struggling or who need more time, who may not appreciate they have more time. Those are the really hard conversations that we have as well about people. Or when you realise that one of your colleagues as a consultant has made a mistake and they've missed something, or something didn't get done which should have been done. Those are really hard conversations to have as well, but we have to have them. So don't fear suppression and lack of being incivil for that reason as well. So I'm going to finish with a couple. I think it's my next slide, probably. So this is Brené Brown. If none of you have heard Brené Brown, if you like TED Talks, try Brené Brown's TED Talk. If you don't like Brené Brown's TED Talk, that's fine, she's not for you. If you like what you hear on Brené Brown's TED Talk, it's one of the 10th most listened TED Talks in the world. So she's an American sociologist who's doing lots of research into emotions, particularly shame. And I think shame is a very powerful emotion that we deal with a lot in medicine. But she talks about things being awkward, brave and kind. And I know you learned about the ABC of everything, and I've now got this new thing about how to deal with life, which is the ABK. So you're called upon to do something where you want to express your concern, you're unhappy or you're distressed. It can be anything. It can be your untidy flatmate, or this terrible plumbing repair. We all have these moments in life where we're at a restaurant and something doesn't like it, but we don't like to complain. So how do you manage those symptoms? So I'd just like to encourage you, for most things where you're struggling with things, take a breath. Don't be afraid to ask the awkward questions, but do it in a kind way. And those things take practice. I recently saw the article the other day about a man who's practicing rejection therapy. He's been struggling with rejection therapy and he gets very sensitive about it. And the way his psychologist is helping him with this is that he has to go up to random people. So, Joe, can you give me £100,000, please? Anyone like to give me £100,000? No. So he goes up to people in the street and asks them for £100,000, and they always say no, but he's learning how to get rejected by that sense of doing that as well. And all these things take practice. So recognise that when you're going to do something difficult, use it as a practice. Say, yeah, I have to do something slightly awkward, and put it down as a practice as well. So hopefully that helps. I've just seen a microphone arriving in case there are any questions as well. But no, there's like an audience mic. Dr. Uman, so. There's a whole pile of references on the next slide. Oh, no. So if anyone wants to check out the reference to that. So those are the references for it in case anyone wants to read it. And if you do, Civility Saves Lives has got a good website as well, which highlights most of those as well. So that's where I'm prepared. That's where I'm going to leave this. So thank you much to the IT guys at the back for saving my bacon. 3 thumbs up. 2 thumbs up. Thank you very much. I'm now handing over to Caroline Whitten.
Thank you very much, and thank you for persevering there under duress.
I think it's cold. I think it was just cold.
It is a bit chilly in here.
Unless I wear a jumper. Thank you.
And thank you to everybody who's attending and to listening to us, and heartfelt thanks to all of our speakers today. It's been much appreciated. Lisa, do you have any final questions? Thank you very much to the IT team, particularly for getting us out of trouble. I'm greatly appreciated. And thank you, Michael, for doing all that work to sort it out.
Well, I don't think we have any final questions. I think some people were struggling to hear the questions.
Okay.
So I just random answers. But I think what we might do is collate them all together, and we can even just write because we've got the live leaders, so I can put together what the answers were.
So for everybody listening, we can collate the questions and we can collate the answers and put them on the live feed. So thank you. So, final words. Go out there, be fantastic doctors, have a wonderful professional life. If you need us, we're here and you know where to find us. So thank you everybody, and goodbye.